Hello, this is the Radiation Oncology Introductory Lecture for RAD 774 for the Penn State College of Medicine. I'm Heath Mackley. The goal of this lecture is to give you a brief overview of radiation oncology, either right before you start rotating with us or early in your rotation, to kind of give you an overview of the field so your experiences can have some context. So we're going to start with the subatomic level. We're going to move up to what happens on a molecular level, continue on through tissue, organs, body systems, and populations. From there, we're going to talk about how radiation is delivered, how do we do planning, why do we use radiation, how's it been studied, and where is the field going. So I like to start with the joke slide. So in 1936, radiation was still a mysterious thing, and it was actually the subject of a horror movie starring two of the biggest stars of the time, Boris Karloff, who was the original Frankenstein monster, and Bela Lugosi, who was the original Dracula. So my joke is, if you ever have a radiation oncologist that reminds you a little bit too much of Dracula, you might consider getting a second opinion. So the electromagnetic spectrum, as you probably know, visible light is just a small section of the spectrum. What we'll be talking about in this lecture are high energy, high frequency, short wavelength electromagnetic radiation. And it is the higher energy that allows this form of electromagnetic radiation to be ionizing. So we'll start with what's happening with radiation. Basically, we're depositing energy into tissue. So the international unit for radiation is absorbed dose is the gray, and the units are joules per kilogram. So as you can see, it's energy in matter. But another way to think about radiation is it's depositing energy in a one-dimensional tract. So it's linear energy transfer is a way of describing radiation where it's depositing energy over a distance. This energy transfer depends on the form of radiation. And so this is the first of many dichotomies we're going to talk about. There's directly ionizing radiation and indirectly ionizing radiation. Directly ionizing radiation is charged. So in our linear accelerators, we have electrons. In proton facilities, the closest from us is Maryland and Philadelphia. Those protons are charged. Alpha particles aren't really used therapeutically, but you've probably heard of radon gas. And alpha particles is how radon gas interacts with your trachea and bronchial tree if you were to breathe it. Indirectly ionizing radiation is non-charged, so it's still an energy beam, but it's neutral, and it itself is causing ionization by interacting with the absorbed material itself and kicking out an electron and causing an ion in the matter itself. So photons is the most common way that we treat therapeutically. Within the world of photons, there's X-rays and gamma rays. They're essentially physically the same. It's just they're differentiated based on the source of the energy. And neutrons are not commonly used therapeutic anymore, but there are still some neutron facilities in the world. So now that we've talked about what happens on the subatomic level, let's talk about what happens on the molecular level. Again, two dichotomies: direct action, indirect action. You can ionize the primary target, which causes the biological effect, which in this case is DNA, or you can ionize something right next to it. And as you know, you're a bag of water, so there's more of a higher probability event of hitting the water than hitting the DNA. So if this is actually the most common form of ionization in X-ray and electrons and proton irradiation, because they're all low LET. The water is turned into a combination of ions, one of which is the hydroxyl ion, and that diffuses to the DNA, causing damage. Because it's a multi-step process, it can be modified with sensitizers and protectors, whereas if you're directly damaging the DNA, there's no intermediate step. And this is dominant in high LET radiation, and so that's why that form of radiation is more biologically potent, because it can't be modified. So we talked about DNA being the source of the biological effect, but many things can happen when you irradiate DNA, and here's a series of things that can happen. But what is most relevant for cell kill are double strand breaks. And this makes sense because if you think about it, well, if you just damage a single strand, then you have the opposing strand next to it, which can be used as a template for repair. Whereas if you break both strands, you're using non-homologous end joining for repair, which is highly error prone and leads to these things down here: chromosome and chromatid aberrations. Many of them are lethal, so they're just basically they're labeled based on how they appear. So there's a dicentric and a ring. These are common lethal chromosome aberrations. But it's also important to remember that there is there's another way that DNA can be affected by radiation. It can just be mutated. And if you cause an oncogenic mutation, then the radiation can cause a malignancy. So we're going to focus mainly on cell kill because we're talking about therapeutic radiation. But keep in mind that one of the side effects of radiation is second malignancy. And so that's where this comes into play. So we cause a DNA double strand break, and again, multiple things can happen, but there's one thing we want you to focus on, and that's mitotic death. So what happens is the cell goes through its cell cycle, and then in mitosis, in the M phase, the spindle formation is, if it's operating correctly, will spread apart the two copies of the DNA so that one full set of the genome is found in each of the two new cells. But if you have chromosomal abnormalities, then this is disrupted and doesn't work. When that happens, the cell isn't able to divide, and it goes through this chaotic death. That's to be compared to apoptosis, which you've learned about, where it's an orderly, programmed cell death, often in embryology, like as in like in the formation of body parts, you have programmed cell death. Now, you do have some apoptosis caused by radiation, but it is a small minority. Just as terminal senescence is another thing that can happen. You can have so much DNA damage that the cell basically doesn't even try to go through mitosis, and it just sits there for days to weeks before dying. With mitotic death, if you remember your algebra, there's a linear quadratic function. Well, that actually is a good predictor of cell death, at least for some types of cancer. So the probability of cell death is a function both of the dose itself and the square of the dose. And that actually, for those of you who are mathematically inclined, allows you to figure out how different schedules can be biologically equivalent. So, yes, cells die with radiation, but they don't all die at the same rate. And that's fundamentally because differences in capacity to repair sublethal damage. In general, radiosensitive cells are less well differentiated and have a greater proliferative capacity. So you think of like basal cells in the skin, which are rapidly dividing and creating new skin cells, or think of like bone marrow, precursor cells, stem cells. And the cells that are differentiated, like say like a muscle that is more radio resistant in general. You also see that in cancers. So you'll find that we treat cancers to different doses, and part of that is due to sensitivity. So like lymphomas are much more sensitive. We give lower doses than we do, for example, a glioblastoma. But even within the same histology, you have differences in sensitivity based on where they are in the cell cycle. Again, that makes sense when you think about it. If you're already in the M phase, you don't have much time for the cell to repair the damage that had been done by the radiation. Whereas if you're in the S phase, the cellular mechanics for DNA replication is already out. That is essentially the same the same apparatus that's used for DNA repair. So it's already mobilized. It's easier and more efficient to repair DNA damage that's been done. Now, for cell cycle sensitivity, that's most relevant to your low LET radiation, like your electrons, your photons, your protons. On to tissue. We talked about cells. Now we're going to talk about tissues. We have another dichotomy here. We have normal tissue that essentially acts like tumor. It acutely responds, and in general, a lot of this is inflammation. So you'll see mucositis, you see proctitis, cystitis, urethritis, dermatitis. And then you also see effect on rapidly dividing cells like your sex cells and your bone marrow cells. Your late responding tissue, they're still affected by the radiotherapy, but you don't generally have acute short-term toxicity. Instead, where you have inflammation in these tissues, after the inflammation subsides, you have collagen deposition, you have fibrosis setting in. That fibrosis can affect the function of the tissue, but it can also affect the microvasculature. So that can profoundly affect like renal parenchyma, for an example, but it can also lead to necrosis of different tissues, bone necrosis, cartilage necrosis, soft tissue necrosis. And remember, the side effects of radiation depends on where you're treating. So if you're treating a brain tumor, your toxicity, what's relevant is the tissues of the brain. It's not, tissues of, the pelvis. So you will sometimes have patients say, hey, I I have a rash on my knee. Is that because of the radiation to my head and neck? And the answer is probably not. So we talked about tissue. The next level up is organs. Function. Obviously, if you have enough tissue that's affected, you're eventually going to harm the organ, but that really depends on the structure of the organ. You can have a small area of lung get completely fibrosed by radiotherapy, and still not really affect the global functioning of the lungs. Whereas you can cause just a small area of damage in the cervical spinal cord and cause the entire spinal cord to malfunction. It's also relevant to keep in mind with children that organ effects are also, there's also the issue of growth and development. So if you irradiate the bone of a growing child, um, you could cause retardation of growth of that bone or complete arrest of growth. Similarly with development, even relatively lower doses of whole brain radiotherapy can have effects on a child's intelligence, and that is age dependent. So the younger they are in their development, the more they can be affected by the same dose level. Beyond organs, you have whole body exposures. That's relevant in the therapeutic world when we're treating the whole body at once for leukemias as pre-bone marrow transplant conditioning regimens. It's also relevant for nuclear disasters. So if 3 Mile Island had a meltdown, the people who were closest to the exposure, they could die within a day if they have a high exposure that causes brain edema. People that have a lower level but still a lethal dose of radiation could die within a few days of sloughing of the GI tract. Lower doses than that, but that are still potentially lethal, are similar to the whole body radiation in therapy, where their bone marrow can be damaged, and they would need a bone marrow transplant in order to be saved from dying because of complications of not having an immune system or not having platelets. In the populations, when you look at things like, well, based on the number of CT scans that are being done for screening, it will cause this many lung cancers. When you hear things like that, they're not talking about the risk to the individual. They're looking at the risk to populations. And when public policy is being made about these risks, they look at two types of effects. One is an all or nothing, so you either get a cancer or you don't. One is deterministic, where the dose matters. So an example would be, we know from the atom bomb survivors that were exposed to radiation while pregnant that there was more mental retardation in the child based on the amount of dose that the child was exposed to in utero. And so public safety policy is really focused on limiting man-made radiation. So keep in mind, we can't put exposure to zero because there's natural radiation from different sources. However, the general the general strategies to limit man-made radiation to the public are by decreasing the time of exposure, increasing shielding so that there's less dose in the first place in the exposure, and also just by increasing distance by creating space between the radiation source and who's being exposed. You'll notice that all of us in the department have radiation badges. That's because we need to keep track of our exposure. Most of us have little to no exposure, but we need to keep track of it um, in the interest of our health. So radiation effects can be altered because, again, on one level it's joules per kilogram, but we already talked about the fact that there's different LET sources. I'm sorry, different LET levels for radiation. So the same radiation dose could cause a different biological effect based on the type of radiation, but even within the same type. So let's say you're only using photons. By increasing dose, by increasing the number of fractions, by decreasing the dose rate, all of those things are going to increase the relative biological effectiveness. Besides changing the schedule or the type of radiation, you can also add other agents. You'll see a lot of our patients are getting concurrent chemotherapy or concurrent biologic agents. There's an abundance of data in support of that, but there's also prospective data with other things as well. You'll see oxygen as one of them. So giving hyperbaric oxygen isn't commonly done therapeutically. However, just having a patient that has better oxygenation versus another patient theoretically will improve the outcome because oxygen is a potent radiosensitizer. These are some examples of protectors that have been studied in randomized control trials and found to have some advantage. They're not commonly given for numerous reasons. A lot of them have their own issues associated with side effects. But it's just a proof of the principle that beyond sensitizing, you can also protect normal tissues. So this visually shows you how relative biological effectiveness and LET are related. This is kind of where we live. This is where the gamma rays are for our gamma knife. This is where the high energy X-rays are, and the electrons are for our linear accelerators. It's also basically where protons are, although protons do have a bit of a range of 1 to 2. Neutrons, which again I said aren't commonly used, they were popular for a time because they had a effectiveness that was 4 times that of an X-ray. Alpha particles are at this peak of efficiency because the density of the energy deposition as measured by LET is basically the same distance as the distance from one DNA strand to another. So there's the 4 R's of radiobiology, and honestly, I only say that I'm only going to give them to you because people will refer to them. I don't think they're all equally relevant. At the same time, it's one of the things we talk about in radiobiology. So we've already talked a lot about repair. So that's really a fundamental issue in how one form of radiation is effective versus another, or how radiation works or doesn't work in an individual patient. Repair is really the big one, but these other things are relevant. We mentioned the cell cycle issue. Well, if you're doing a fractionated treatment, you're going to preferentially kill a bunch of cells that are probably around M phase. And so if you're able to have your next fraction be enough time so that the cells that were in S phase that you weren't able to kill as efficiently, they've all kind of moved to M phase, then the redistribution will be to your advantage as long as the fractionation is timed to keep knocking off the cells that you weren't able to knock off in previous fractions. Reoxygenation is relevant in the sense that the environment of the tumor is dynamic. So there are some areas that are hypoxic relative to others, and because of hypoxia, that's one of the mechanisms of resistance, because as we said, oxygen is a sensitizer. So as a tumor undergoes this change while it's being treated, and some areas that were hypoxic become oxygenated, you're better able to treat those areas over time. So it's again another reason that fractionation can be helpful. I should go back to repair and saying that another reason that fractionation is helpful, specifically with regard to repair, is that in general the cancer cells are less efficient at repair than the normal tissue. So by doing fractionated treatment, you're able to achieve a therapeutic window where you're killing more cancer cells than you're causing normal tissue damage. The last issue is repopulation, and this is where fractionation can kind of hurt you if you extend the treatment time out too long. Because again, the tumor environment is dynamically changing, and some of the cells that are still alive after a number of other cells around it have died will actually become activated and will start dividing more rapidly. So at a certain point in a patient's treatment, the remaining cells are dividing more rapidly, and so it is more efficient to get your treatment done in a shorter period of time in order to avoid the effects of repopulation. So this is borne out in a couple different types of cancer, one of them being head and neck cancer. So once we start treatment, our goal is to get the treatment done as close to on time as possible to avoid the deleterious effects of repopulation. So here's another joke slide. Radiation. It might be a lot of fun, but sometimes it can go bad. Okay. There's two types of radiation. Brachytherapy and teletherapy. Two ways of delivering it. We've got another dichotomy for you. So brachytherapy is a way of delivering radiation either in or right next to the target. And this can be done in a cavity, like putting a radioactive seed, like for example, inside of a uterus. It could be interstitial, so putting a number of radioactive seeds, for example, in a prostate. You could also take something liquid and put it in a catheter and inject it into the liver, or inject it into a cystic tumor in the brain, or injected into the peritoneal fluid. Oral administration would include like iodine 131 for thyroid cancer. So the other major type of treatment is external beam. This is the majority of what we do in our hospital. And we commonly use intensity modulated radiotherapy, which we'll talk about in a bit. More traditional external beam radiation, where you have a limited number of fields and you're not modulating the beam. Radiosurgery, we do that both with our linear accelerators and with our gamma knife. We'll explain that more in a bit. And then proton therapy, which we alluded to earlier. But first, we're going to talk about solid brachytherapy sources. We have one of these. It's a Iridium 192 HDR unit. HDR stands for high dose rate. See, we have another dichotomy: high dose rate, low dose rate. High dose rate's treated over about 15 minutes at a time. Low dose rate, if temporary, is a few days. If permanent, it just stays inside of the patient permanently, although because of radioactive decay becomes essentially inert after a period of time. With our HDR unit, inside of here is where the source is normally, but if we have the patient in the room and we have whatever applicator is inside of the patient connected to catheters that connect to this, then when everyone leaves the room, the source will go out of here, in through the catheter, into the patient for like 15 minutes. So brachytherapy applicators, there's many types. So I'm just giving you a few examples. But basically, if you can get inside of a patient in some way, you could deliver brachytherapy. We do a number of GYN procedures in our hospital. So if a woman has a cervical cancer, we'll place this part of it inside of her, where this tandem portion goes inside of the uterus, and these ovoids are next to the tandem, and they bring dose out to the paracervical tissue. You basically have these three channels, so the source will go into one channel, stay here for a little while, pull out, go into the second channel, kind of deposit radiation the whole way along the tandem, and then come out again, and then come in the third channel and go into the other ovoid again. A simpler GYN device is a vaginal cylinder that it only has one channel, and it may be used to treat vaginal cancer or just to treat the end of the vagina if that's an area at high risk of recurrence after hysterectomy for a uterine cancer. For prostate implants, they're usually given in needles that go through the perineum into the prostate directly. For like patients that have recurrent neck cancers, where previous radiation's already been given, a lot of times they'll remove the tumor, they'll lay catheters in the bed, and then there will be, say, about 5 exposures for the patient, and then they'll just pull the catheters like pulling a drain. For patients that have tumors inside of a bronchus that's causing a malignant obstruction, a bronchoscopist may go in and lay a catheter in that hole, and then we can have the source go in through the catheter, do the exposure, and then we pull it out again and then just pull the catheter. This is a way to deliver radiation focally in the back of the nasopharynx for a boost. So here's some pictures of different external beam devices. This is what a proton facility looks like. The actual particle accelerator is it's out of the view of the table because it's usually like 3 stories high. This is the gantry. So this is where the beam is actually coming out. The patient's laying on the table. You'll see a gamma knife at our hospital. The patient lays on the table, their head goes inside of here, and that's where the exposure happens. This is a linear accelerator. We have a number of them at the hospital. The patient lays on the table, a beam comes out of the front, and it can rotate around the patient and treat from lots of different angles. So we use electrons for superficial targets because it deposits its energy superficially and there's little exit. We use X-rays for deep targets, but there is exit, so the beam passes through the patient. The gamma knife uses gamma rays, which are basically physically the same as X-rays. It's just there's 200 sources, each of them having one beam, all pointed to the same spot in the middle. And then for protons, they're also used mainly for deep targets, but they have no exit, making it very similar to electrons, and they have very little entrance. So it's a very elegant way of treating a deep target non-invasively. This is a schematic of the inside of a LINAC. So you have a little gun that shoots electrons in a rhythmic way. The electrons accelerate to nearly the speed of light in this waveguide, which is powered by a microwave generator. It gets to nearly the speed of light. It hits a tungsten target. And then when the electrons hit the tungsten, that creates a spectrum of X-rays. At the head of the beam, you have filters and different types of blocks which narrow the spectrum of the X-rays and also modulates the intensity of the beam, in some places blocking it completely and in other places just attenuating it, which allows the beam to be very reliable, geometrically accurate, and it enables you to conformally treat the target that is that's in the patient. Intraoperative radiotherapy is a form of radiation that kind of is like a combination of brachytherapy and external beam, because it's like external beam. It's creating a beam, but it's very superficial, and it's being placed inside of the patient in the operating room. For example, in the abdomen after a sarcoma is resected, or in a tumor bed after breast cancer resection. And it's an elegant way of very focally delivering radiotherapy. So we're going to talk about a few acronyms that you'll hear passed around. Intensity modulated radiotherapy, or IMRT, is a way of delivering radiation conformally to a deep target. So this is basically like a prostate, and you can see there's lots of different beams. They all intersect at one point. So that's one way to deliver the dose more focally, but beyond that, the beam itself is very complex because there's leaves on the head of the machine which modulate the intensity. So this color map is basically showing the relative differences of high doses versus low doses. And you can see that you can have very complex dose distributions on each beam angle, and they can dynamically change. So that it's the beam angles plus the intensity modulation that really helps you put the dose where you want it relatively. For image guidance, our linear accelerators have X-ray imagers on the LINAC itself. So when the patient's in position to be treated, right before you turn the beam on, we can get either conventional X-rays or a limited CT scan. We call that a cone beam CT, which will give us confidence that the area we're treating is what we want to treat. That enables us to have tighter margins, so that way we're treating less normal tissue and hopefully causing less side effects. Stereotactic radiosurgery is a term that it's not involving cutting, even though as radiosurgery as its name. It was actually invented by a neurosurgeon, which is, I guess, how it got the surgery put into its name. But it's a way of delivering precisely aimed, highly focused beams that converge at a specific point. So what do we mean by precisely aimed? Well, the geometric precision of our gamma knife is way less than a millimeter. It doesn't have to be a gamma knife. You can do this procedure with linear accelerators, protons, even carbon ions. In general, you're giving high doses, so you're trying to ablate tissue. And so in the beginning, it was always single fraction. Over time, radiosurgery has expanded a bit to also include up to 5 treatments, although we commonly use other names for that, like stereotactic body radiotherapy or stereotactic ablative radiotherapy. So you'll hear SBRT and SABR thrown around a lot as well. As I alluded to earlier, on the inside of the gamma knife, you basically have a point, and your mission is to get the patient's tumor to go into the point of the machine where the high dose is. You have 199 sources, somewhere around that. It's a little less than 200, of cobalt-60. It's giving off radiation in all directions, but it's completely shielded. So there's only one little collimator hole where the radiation beam can get out. We have different sizes of collimators, but they're all pointed to the same point. So everything's relatively weak around it, but you have this high dose point in the center. So it's a really elegant way of delivering focused radiation in the brain. Here we have another joke slide. If you ever have a radiation oncologist that looks as nervous as this poor guy, you probably need another opinion. So I'm going to give you another dichotomy. I think there's 2 main things to think about when you think about how do we make a plan. You don't want to miss the target, because that's the only way it's going to work. At the same time, you don't want to harm the patient. So you have these 2 things that are equally important that you have to constantly keep in mind. You have to hit the target. You have to hit it with enough dose. If you don't give it if you don't do enough to control the tumor, you're exposing the patient to side effects, but you're not solving their problem. It's a focal treatment. So part of not missing the target is knowing the limitations of what you're doing. If you're treating a lung cancer with curative intent, but the patient already has microscopic disease in their brain and they develop brain mets 3 months later, no matter what you did in the lung, whether it was effective or not in treating that lung tumor, you've not cured the patient because your intervention is only a focal treatment. And then finally, there are times where the patient's just at really high risk of developing more cancers. You'll occasionally see patients with oral cavity cancers They just keep making a new one every year or two. So you may cure the one cancer, but if there's this baseline level of genetic mutation which makes the rest of the mucosa susceptible to creating a cancer, you still may not have solved their problem. And, toxicity is, of course, equally important. On one level, you could just keep giving higher and higher doses of radiation and kill any cancer. But if you kill the patient in the process, you obviously haven't helped them. But even beyond that, any amount of overtreatment, any amount, is giving unnecessary toxicity. So our first step in planning a simulation, we want to get a set of imaging in a reproducible treatment position. So we want to use that set of imaging to actually make the plan, but that the reproducibility is important because we want to have a position that we can exactly replicate for each of the treatments. So the first thing we have to do is figure out what position are they going to lay in. On their stomach, on their back, are their arms up or down? And the patient's comfort level is important because an uncomfortable patient is probably not going to be reproducible. Besides just having them lay in a position, we may have a device that helps them stay in that position. The most potent of that being anesthesia. I mean, if you have a small child, a lot of times they need to be asleep for them to lay still. When you acquire imaging, we generally do CT scans, but there's other ways of getting imaging. And beyond that, with the imaging, you have to think about it in terms of, well, this is a diagnostic scan. Do I need contrast? What thickness should the slices be? What part of the body exactly do I need to scan? So that needs to be worked out ahead of time. And then finally, after we've set them up, scanned them, then we mark the patient. A lot of times you're just marking the immobilization device, but there are times where we have to either draw on the patient or give permanent tattoos, which our laser system can line up to. So as I said, we have a CT simulator, but you can simulate with MR, PET, and or conventional X-rays. This is just an example of what conventional radiotherapy looks like. You basically shoot an X-ray in the position you want to treat them, and then you draw on the film what you want blocked. So here's another dichotomy. There's two basic ways to immobilize a patient. You can have something on top of them, so like a mask over their head, over their pelvis, or you can have a mold under them that's reproducible. So this is like a vacuum bag. This is actually a combination of vacuum bag plus something over top of them for a radiosurgery procedure. So you get imaging, but the patient may have other diagnostic imaging that you find helpful. So we often use MRs, PET scans. They give us more anatomic information that helps us delineate what the target is. A lot of times that other imaging is not in the same position as the CT simulation. So we fuse it, and we do have software which allows for deformable image co-registration, kind of getting around the different position. But keep in mind, it's only as good as the algorithm of the software. So then, once the imaging's in place, I have to outline what the structure, what the target's going to be. Again, we have lots of acronyms here. If I can see the target, say like a lung cancer, that you can see like an area in the lung that's clearly a tumor, we call that a gross tumor volume. Now, even if you have a gross tumor volume, let's say a glioblastoma, I can see it on the MRI with gadolinium pretty clearly, but I also know from surgical series um, that there is microscopic extension beyond the gross tumor. So if I want to treat everywhere where there's disease, I have to have an expansion on that GTV, and I call that a CTV. Now, there are times when there's no gross tumor, like, for example, breast cancer is removed. All you have is a postoperative bed and plus or minus treating the rest of the breast. So it's actually that postoperative bed is your CTV in that case. But beyond that, the target, which is basically based on anatomy, that anatomy might move. And so you have an ITV where you have to take into account, well, does the target move due to breathing? Does it move due to bladder filling or rectal filling? And so you, by taking into account for that, you have an expansion on the CTV. For the planning target volume, you've taken into account this, but there's one more thing, and that's daily setup error. Because no matter how efficient your therapists are, even with image guidance, it's not perfect. So it's this final PTV that becomes the focus of your prescription. And oftentimes you'll have more than one PTV that gets different dose levels. For example, for someone with a tonsil cancer, you may treat the high-risk PTV to one dose level, and the neck lymph nodes where you can't see cancer, but you know there might be microscopic disease, you may prescribe to a lower dose level. Now, once you've outlined the target, there's still organs at risk you want to take into account. Because remember, rule number one, cover the target. Rule number one, don't harm the patient. So you outline the areas you're concerned about. So if you were treating that same tonsil cancer, you might want to outline the parotid glands, the mandible, the spinal cord, etc. And so each of these organs at risk, you'll want to give a constraint. So just as you gave a prescription for the PTVs, you also want to give constraints. And so an example would be you want to limit the median dose of the parotid gland to be less than 25 gray, for example. Then your dosimetrist will then take all of what's been done, the constraints and the prescription, and they will do their best to fulfill all of those goals or even exceed them simultaneously. There's two main ways to plan. One is forward planning, where they take the different variables that they can adjust, like size of the field, angles, that sort of thing, and they go through an iterative process of trying different plans until they find the one they like the best. The other is inverse planning, where you give the computer all of the parameters of the prescription and then let it try to maximize the parameters of the plan. For IMRT, that in most cases has to be inverse planned. Brachytherapy is similar, but instead of setting up beams, what you're doing is you're figuring out, well, based on the placement of the channels, where do you want the source to be, and how long does it need to be at each source location to, again, cover the target but not exceeding the tolerance of the organs at risk. Once the plan's done, I go back and take a look. I'm looking at a couple things. Number one, did I cover the target? So I may have specific goals, like I want the minimum dose of the PTV to be 95%. I want 95% of the prescription dose to cover 100% of the PTV. And then again, equally, are the critical organs at risk being spared? If all of those things are possible, are we able to decrease dose to less critical structures, but ones that still help impact the patient's quality of life? If that's able to be done as well, are we able to decrease the volume of tissue being treated? This is relevant especially in younger patients who have a higher risk of second malignancy. If we can reduce the volume exposed, we should decrease their risk over time. As you're looking at all these things, it's important to remember that you can't change the laws of physics. So you want to have realistic goals that can be achieved. Otherwise, you're just banging your head against the wall. So once I've approved a plan, it needs to be double checked by a physicist, and they look at each individual plan. They'll actually irradiate a kind of a fake patient, a phantom, to see if the plan that we created, the actual dose being delivered in the phantom, is within a certain tolerance of what we predicted. For non-RT plans, we usually use a different set of software to do an independent dose calculation. And the physicists are also involved in the machine quality assurance, because over time, we want to know that the beam is reliable, that the software is reliable, and that what we believe we're delivering, we are in fact delivering. Once it's past QA, then we do one final test run on the machine itself. This is often called an isocenter check or block check. And we ensure that the immobilization device still fits, the patient lines up well for each beam, and that none of the beams chosen are impossible to deliver, which, despite the software being pretty refined, it's still possible to plan something that can't actually be delivered in the real world. So then the treatment's being delivered by a therapist, either every day or once a week. Imaging is being checked on the machine by the therapist. I review that on my computer. I also see the patient with a nurse at least weekly to do a toxicity check and make sure they're doing okay. So this is a basic picture of why do we do this. I mean, and these aren't exactly related, but the concepts are related. So if you have a tumor here, in the old days, they would have had one from the right and one from the left for beams, and everything in the middle here is getting nearly the maximum dose. With the 3D conformal treatment, where you start having lots of different angles, but you have open beams that aren't modulated, you're able to get a more conformal treatment, but when you added intensity modulation, it becomes even more conformal. This compares IMRT to protons. As you can see, the conformality is not super different, but there's a lot of brain getting low dose with IMRT compared to the protons. This is not an accepted way to deliver whole body radiation. This is a 1940 film, Dr. Cyclops. Okay. Why do we treat? Another dichotomy. We're going for cure, we're going for palliation. So with cure, there's two ways of doing it. One is the radiation itself is curative intent. An example would be a vocal cord cancer. Radiation by itself can cure someone. Or even with locally advanced vocal cord cancers, adding chemo to the radiation improves the cure rate, but the radiation is still the backbone of the treatment. In many situations, radiation is an adjunct. So, like for breast cancer, the surgery itself could have cured the patient, but they have a risk of recurrence that we can reduce with radiation. So the radiation is improving the cure rate of the surgery in this multimodality setting. For lymphomas, you see the same thing when you give radiation after chemo. In palliation, there's two main reasons that we palliate. One is because the patient has pain, bleeding, an actual symptom. We're trying to help it. We're usually giving a lower dose than a definitive treatment so as not to cause as bad a side effects. But another reason we treat in palliation is the area isn't causing a symptom, but it will if it progresses any further. So an example of that would be a small asymptomatic brain metastasis. Another would be having a bone metastasis in like the head of the femur where there's a risk of pathologic fracture. In the hospital, these are reasons why you'll commonly have inpatient consultation requests for radiation. If someone's having symptoms from cord compression, they'll usually start them on steroids, but either do a surgery or radiation quickly after that. For superior vena cava syndrome, this isn't quite as life-threatening, but the patient's still symptomatic and needs treatment relatively quickly. This also might involve a surgical procedure like a stent placement in conjunction with radiation. Hemoptysis is something we're often able to help a patient, and that can potentially save their life over the short term. And for patients that have symptomatic brain metastasis, we want to get treatment going for that as quickly as possible. So this is kind of a busy slide. It's just to give you an overview of, for adults, what do we commonly treat in the curative setting? Qualitatively, you can kind of see from head to toe, it's a lot of different malignancies and benign tumors. Same thing in kids. Not as many as adults, but it's still kind of from head to toe, lots of malignancies, and also some benign tumors. These are less common things that we use radiation for in the curative setting for adults, but there are individual circumstances for these less common, for these other types of cancer that we still use radiation in the curative setting, both for adults and for kids. So it really shows you that a radiation oncologist needs to have a wide and deep knowledge base in order to have a understanding of all of the reasons that radiation might be helpful. Doses are kind of all over the place, but if you keep a couple things in mind, I think it gives you a good ballpark to start. For standard treatments, kind of have 2 gray per fraction in your mind. For gross disease, 60 to 70 gray. For microscopic disease, around 50 gray. For lymphomas, maybe around 30 gray. And for total body, around 12. Palliation, we commonly use 30 gray over 2 weeks or just 8 gray times 1. And radiosurgery doses it's a pretty big range, but when you think that a lot of this is over just a single fraction, it's a pretty hefty dose. For kids, it's not that different. The doses in general are lower. Neuroblastoma, Hodgkin's, Wilms tumor, these are all things that are more sensitive. We give lower doses. But the brain tumors and the sarcomas, the doses are similar. The gamma knife doses are similar. The total body radiation is similar. Two things that are consistently different with kids that you don't see much in adults is for some tumors, we will give whole lung radiation at a relatively low dose. And for some brain tumors, they have a high risk of seeding in the CSF and will actually treat the whole craniospinal axis. Standard radiation is once a day, 5 days a week. Again, keep that 2 gray in your mind. Anything more than that, we call it hypofractionation. That might just be like radiosurgery where you're giving a few really big doses, but it also might be you're giving like 2.4 gray per fraction over 4 weeks for a melanoma. Hyperfractionation, the doses are generally smaller per treatment, maybe around 1.2, 1.5. They're given oftentimes twice a day. This used to be more widely used in different cancers. It's still used sometimes today, but less commonly. And then accelerated fractionation is when you're giving more than 5 fractions a week. So that could be in the context of hyperfractionation, or it could just be for a head and neck cancer, you're giving 2 gray per fraction once a day, 6 days a week. That is not commonly done, but there are times when it's done. Another joke slide. Ah! Okay. Prospective randomized trials have studied. If you can think of it, it's probably been studied. We've looked at, like brachytherapy versus external beam. That would be like a modality question. We've looked at technology questions. Protons versus photons. IMRT versus conventional. We've looked at volumes. Can we get away with a smaller target? Can we not do elective coverage and decrease toxicity? Other times, should we have a bigger target so that way we have less marginal failures? Should we add sensitizers? As I said, there's lots of trials about concurrent chemo, less so about protectors, but they are out there. What's the role of radiation? Surgery plus or minus radiation, or radiation versus surgery. An example of that would be anal cancer. Surgery can treat anal cancer, but chemoradiation can often spare the patient a permanent colostomy. Then just looking at radiation, there's the schedule. Should you have a higher dose? For some things that's true, for other things no. Can things that we used to give higher doses, can we get away with a lower dose? Like an example for that would be our lymphoma doses have been getting smaller and smaller over time. There's once a day versus twice a day trials. There's hypofractionated versus conventionally fractionated trials for breast cancer, for lung cancer, for others. When we're studying radiation, we do care about the important, the things that everyone agrees are important. Survival, preventing relapses of the cancer. But we also care about local endpoints because this is a regional treatment. Are we preventing local failure after surgery? which prevents another surgery from needing to happen. What's our response rate? What's our organ preservation rate? So how many times can we avoid the person losing their voice box for a locally advanced larynx cancer, as an example? For palliative treatment, we care about pain control. For palliative and curative treatments, we care about quality of life inventories as well. I'll also throw out that there are patients that seem to be more sensitive to radiation and might have a higher risk of toxicity. So these are things to keep in mind if you see those patients. It's relevant if we're treating that area. So if they have ulcerative colitis, it's relevant if they have rectal cancer. It's probably not relevant if they have tonsil cancer. So how can we improve radiation? Where are things going? Well, the biggest thing is, well, I mean, these are all big things, but one of the biggest things to me is who really needs it? You go back to the example of breast cancer or prostate cancer. A lot of these patients are being treated aggressively because on average there's a benefit, but we know that a lot of patients, they didn't need that aggressive treatment and would have done okay without it. We really need better predictive tools so we know who needs treatment and who doesn't. On an individual basis, it would be great to know, hey, does this patient have a sensitive tonsil cancer or a more resistant one? Can I get away with a lower dose? Or if I do a standard dose, are they doomed to failure and I need to give them a higher dose? Again, it's not only who needs to know it, but what's the minimal efficacious dose. And we need better tools that will enable us to do that. The better we're able to know where the target is, the better we will be able to avoid treating normal tissue. The better our technology improves, the better we're able to give higher doses when we need it, but also decrease toxicity and improve quality of life. And then finally, if we could get better radioprotectors or less toxic radiosensitizing drugs, we'd be doing a great good for our patients. And of course, all of these things need to go through a strict process of phase 1 through 4 studies, which I'm sure you've been exposed to. So that's it. We look forward to having you rotate with us. Feel free to ask us questions. We are genuinely concerned with having you get as good of a educational experience as possible. So please give me feedback on this lecture as well. Thank you.